Mr. Chairman, hope you can hear me. Mr. Chairman, Felix, colleagues and friends, it's a great pleasure to spend this beautiful Sunday afternoon here inside and not outside. It's rainy and foggy, so there's no better place than to be here. When I've been listening to the last two presentations, especially the first one, you might feel this presentation is old-fashioned in a way. Even if I will report about the newest technology and sensors, nevertheless, it seems definitely old-fashioned compared to the future we have seen with Darth Vader and his colleagues and friends. So, as you have heard, I'm not a specialist in congenital heart disease, but I'm an interventional cardiologist and treating a lot of heart failure patients. And so the question is always, can we have any tool, or do we have any tools to predict any decompensation to improve mortality and first to avoid any rehospitalization, which is really important for the patients to stay outside the hospital and to stay at home. So we always have the idea to look into the future, not in all these movies we have seen, but to predict and to prevent. And the key problem is right here. As soon as the patient starts suffering from heart failure symptoms, there's only a few days of reaction time until we can avoid hospitalization. So even if the patient shows up or calls us with symptoms, there's only a few days, and sometimes we cannot avoid hospitalization. The key question is whether we have any data which comes much earlier, which are pre-symptomatic in those patients, and we will use the gap between increase, for example, of any kind of pressure we can measure or any other invasive data, can we then avoid the hospitalization or even work on the patient's reduced mortality. So that's important to keep in mind. There's a gap of days or even weeks in between increase of invasive data or change of invasive data and the clinical shoreline. So we have to have two different definitions. We have the so-called hemodynamic congestion, which are data we gain, but we have no overt clinical congestion. And we have the clinical congestion, and it's not predictable when a patient with a hemodynamic congestion will show up with clinical congestion. It depends on the rapidity of rise, duration, magnitude of the left atrial pressure changes, and so on. So it's not 1 day, it's not 10 days, it might be up to 30 days until a clinical decompensation follows the hemodynamic decompensation. So if we want to talk about sensors, we have non-invasive sensors. Probably Friedrich Köhler has discussed this yesterday already. But we also have, meanwhile, a lot of invasive opportunities. So we can gain a lot of technical data based on implants like pacemakers, ICDs, CRTs. Those data will come out of electrodes, out of the battery, and based by those intrinsic intracardiac signals, we also get information about the rhythm, we get information about the ECG signal itself, and we also can use the impedance between the lead and the device itself for getting impedance, the intrathoracic impedance, which might be a matter or a sign of increase of fluid, which is influencing the impedance. We also might get by leads and the device heart rate and respiration rate, also information about activity, and then finally, which is of major interest, trying to get directly information about pressure. We try to get pressure on the RV, in the pulmonary artery, in the left atrium, and meanwhile also trying to get information of the left ventricle. So these are data from normal heart failure patient, not congestive heart failure, but congenital heart failure patients. But you can imagine that you might apply all these sensors just depending on the catheter technology on every place you will reach. So non-invasive remote monitoring is already well known. We have weight, we have blood pressure, and different other things. But this is not all completely reflecting the physiological state of our patients. That's why we have physiological invasive monitoring and we have hemodynamic invasive monitoring. And the data have been frustrating regarding the last years. But when you try to understand all these trials, you will see that's also a matter of reaction. Data are all, only good if you react in a certain way. If you just gain and collect data and there's no algorithm-based treatment of those patients, the value of those data is completely lost. If we go for the physiological monitoring, so we started with the so-called Medtronic optimal system. Probably a lot of you already know the system for many, many years. Just looking for the impedance between the lead and the device, and as soon as impedance goes down, you have an increase of fluid in the body, which might predict any decompensation. So always those information starts with data going back into the history. And it's easy to say, look, we have impedance data. 6 weeks ago, there was an increase of, or a drop of impedance. And now the patient is in hospital 6 weeks. That looked always fine if you go retrospectively. But the idea is to predict and prevent. So we have the MoreCare trial and the OptiLink trial, and both trials failed. There was no improvement regarding the primary endpoint death and cardiovascular hospitalization if you use the atrial arrhythmias and versus usual care, or if you use the fluid status based on impedance. So this was really frustrating and not helpful if you want to avoid anything for the future. Those are the data from the OptiLink trial. All-cause death, cardiovascular hospitalization, completely identical, means, okay, this is probably not alone. If you just look for impedance and arrhythmias, it's not a good tool to prevent anything. This tool alone seems not to be helpful. So did not show superiority of a specific intrathoracic impedance and telemedicine-based heart failure disease management over standard clinical assessment. Randomized, controlled, so that was disappointing. That was just a modification of this approach, some so-called MoreCare trial, same result finally, so that everybody concludes probably impedance alone is not helpful. So this is a conclusion published in the European Journal of Heart Failure 2017, did not reduce mortality or risk of cardiovascular events, device-related hospitalization. So it was disappointing, and we had to move on. So what would be the next step? The next step would be trying to combine more information which comes out of the devices. You can look for heart rate, you can look for activity, you can look for impedance as well. And this is the idea of a so-called multi-sensor algorithm. That means different information is put together and it's balanced or weighted differently. Nobody of us knows how it is balanced. We always ask the company. This algorithm is developed by Boston Scientific, but you never ever hear or are able to get the information. Is heart rate important, whatever? First, these are the information which is used. It's the heart sound, the first, the second, the impedance, respiration rate, heart rate, activity. And out of these, an algorithm is built which tries to predict a decompensation, and this one seems to work. So both endpoints has been reached completely, and the predicted threshold of this algorithm has been passed in the majority of patients up to 34 days. That means this algorithm seems to be helpful in predicting a decompensation within one following month, which is quite a long time. So this is important to keep in mind. So in parallel, a different trial, which was really enthusiastically commented, mainly supported by Gerd Hinrichs in Leipzig, the so-called in-time trial, where parameter from implanted ICDs were used and superiority in cardiovascular events has been shown. This trial was successful because early arrhythmias have been detected and has been reacted. If patients had atrial fibrillation, atrial flutter, this was easily detected in those devices, no problem nowadays, and a reaction occurred. So this is mainly successful not in predicting decompensation, but early reaction on arrhythmias, impedance, meaning a lead impedance, so a failure of the device, but it's not a typical heart failure preventive prediction trial. So finally, we might come to the so-called hemodynamic monitoring, and some of you might remember the time. It's more than probably a decade ago when Medtronic developed the first lead, which was placed in the RVOT and was able to detect more or less pressure. The sensor was not stable, it was clotted, so that fibrotic tissue on it, and the first trial, the so-called COMPASS trial, was negative. Based on these ideas, there were different sensors meanwhile developed, and the champion trial is the first positive trial with a so-called pulmonary artery pressure sensor, and we will go into detail a little bit further. 345 patients, primary endpoint heart failure hospitalization at 6 months, 33% reduction in heart failure hospitalization in the treatment arm, and it's definitely extremely important to understand the design of the trial and also about the CardioMEMS sensor. This is the sensor itself. It's a very tiny batteryless sensor, so there's no battery inside. That means it's extremely tiny. You see it's 15 millimeters and has those two 90-node loops, can be delivered via catheter in the pulmonary artery, and allows a communication later on. That's a comparison to €1. So here you see first you have to perform a pulmonary angiogram, and then this one is pushed out of the catheter, and with its two loops, it's finally fixated in the pulmonary artery, allowing consequently measurement. But this is real life. It's a Berlin patient in his living room, so it's far away from the futuristic things we have seen. That's real life. And that's technology which is available nowadays. That's how we have to work, to get pressure information every day. You see this pillow, he explaining it, it was a live transmission. He has to put himself on this really, I wouldn't say comfortable pillow. And then he is guided through the program step by step. It takes probably up to 5 to 10 minutes. This patient has a chronic embolic pulmonary hypertension, and he got a pulmonary artery pressure sensor with our colleagues from Buch to guide his therapy for the next time. And so we could always see he has a PA pressure of 80 at rest, and so we could titrate in cooperation his medication. But just want to show you that it's not that fancy. It has to be active. You have to do it actively day by day. You get a message back from the center, which are we are and say, okay, transmission successful, and then we are looking at the following data. Just to give you this information, it's not the future. That's one of the another patient who received such a CardioMEMS system, 66 years old, dilated cardiomyopathy. I think it's clear for its ejection fraction, extremely low. He got everything you can do nowadays. He got a CRTD. He was decompensated repeatedly and has a severe mitral regurgitation. So this case was discussed with a cardiac surgeon. He said, no idea, we don't want to go for surgery. Ejection fraction is so low, and he is decompensated extremely often. So everything was titrated, including Entresto, to the maximum of tolerated dose. And you see the situation during the procedure, and then he finally got a transapical mitral valve replacement. You see in here a quadrupolar LV lead on a good place, ICD lead. So this was a minimally invasive approach to cure his mitral regurgitation. You can see the well-working valve inside here. And hemodynamic, it was extremely complicated for the next weeks. So he got an impeller for 5 days. The left ventricle definitely suffered, despite the fact that the mitral was extremely fine. So, but you could see right here the CardioMEMS system to demonstrate and to follow him consequently and to guide his therapy all over the time. So you see the valve right here, but the left ventricle is not improving. It's definitely unpredictable what will happen to those left ventricles if they're already suffering at the beginning. Despite a well-functioning mitral valve, you can see the invasive data in here. You see this pulmonary artery pressure. Systolic pulmonary artery pressure is not that high. That's the mean artery pressure, and that's the diastolic. So the key is always here. If you see, for example, an increase in those days, what will you do? Will you increase diuretics? Will you increase vasodilators? Will you call him today at home? You say, come in, whatever. So that's the key question. How can we avoid any further problems by getting this information? That, as you see right here, there's a fluctuation all over the time, and it goes up and down, but finding out when is the best time. So coming back to the CHAMPION trial, it's quite interesting to see how the treatment group, which had the CardioMEM sensor, was treated. You see, the changes and the adaptation of the medication was at least double or 3 times higher than in the standard group. You see, their diuretics were increased and also down titrated if the PA pressure went down, compared to the pointed line right here, which is the control group. So the early reaction is extremely important, time-consuming, and also in a way probably cost-consuming. That's for sure. So, okay, this is a pulmonary artery pressure. The idea is, okay, if we get directly the left atrial pressure, we are much closer. We have the whole pulmonary part aside. We are directly facing the left ventricle. So the first generation of so-called lab monitor was constructed by Abbott, the so-called heart pod, which is looking like a pacemaker. This one is not stimulating, it's just the electronic part inside for transmission later on. And this lead was put through the left atrial septum, and the trial was the so-called laptop HF trial. Unfortunately, out of the intended 670 patients, after 450, the trial was stopped due to safety reasons. Wherever you try to figure out what are the reasons for the safety concerns, you wouldn't find it was embolic, perforation, migration, whatever. Up to this point, there was no reduction in a combined endpoint, so there was also some kind of frustration in this point. So that's the newest generation, as you can see right here. It's a left atrial pressure monitor published in 2017, and just a few days ago in Journal of Cardiovascular Translational Medicine, a novel wireless left atrial pressure monitoring system for patients with heart failure, first in animal data. It looks like a device which is probably well known by all of you. It looks like a PFO or ASD occluder, having more technology inside. It's delivered via a transseptal approach, and it's measuring right here the pressure in the left atrium. And next step, also just recently published, the idea how can we probably monitor the left ventricle itself. So you see this one, it's in dogs. Right here, it's a very tiny micro electromechanical system, like the CardioMEM system, called the LVMEM system, 13.9 millimeters and 1.6 square millimeters in here. It's screwed into the myocardium of the left ventricle. 5 dogs were treated and compared. It's batteryless, and you see those invasive data right here. You get all the information from the left ventricle, relaxation, contractility, time concept relaxation, and those dogs were made were treated to suffer from heart failure by rapid pacing, and you can distinguish between heart failure and the normal dogs overall. So what are the guidelines? Finally, it's not really good for everything. It's very low importance of that. You see a heart rhythm expert consensus conference in 2015. Use of remote monitoring in all forms of implantable electrical devices. It's 1A. Heart failure using thoracic impedance is 2BC. ACC guidelines, no comment. and ACC guideline heart failure, which has been presented dealing with just before, also as in ICDs. That's the final 2 slides. It's a consensus whiteboard paper which tries to combine and give you an advice with all those sensors which are developed and gone already. So pressure monitoring in the right ventricle, which was the compass with the chronicle lead, unable to show improved patient data. Laptop, which was left atrial pressure, failed owing to an excess of complications. CardioMEMS resulted in fewer heart failure hospitalizations than standard care with recent heart failure events. And now the final question, who should get all those stuff, which is not well paid? So we have to pay more. It's not reimbursed, so it's not covering the costs by the health insurance. So the data we are, if in normal heart failure patients, if the pulmonary artery pressure systolic is increased above 15 to 35 or mean or the diastolic pressure, then it's time to react. The window of opportunity to titrate, optimize heart failure medication, increase diuretics, vasodilators, and sometimes you also have to reduce it. It's important that the patient submits data daily. You have seen it's not a real fun to lay on your pillow every day. That could be much easier and much fancier. And there has been algorithm underlaid how these patients have to be treated and how somebody has to react. That's the key problem in all the previous. If there's no algorithm, no clear structure, some doctor will say, okay, give him more, some say increase thiazides, whatever. So we will be successful finally if it's a clear structure with responsibility of one center or two centers, whatever, and of doctors who know the patient when this monitor is implanted. Thank you very much.